Welcome to Radio Omnicore, episode 44. In this episode, we're interviewing Dr. Carron Zinman. She's a pulmonologist at the Linksfield Clinic, and she spends time reflecting over her last few months as she's worked as a pulmonologist. And in her words, she's had to navigate the war of COVID, and it's been a very real conversation just to be able to chat to a doctor who's been at the coalface of dealing with this pandemic. It's very fascinating. For those of you who are sensitive, just a warning that's quite graphic, lots of medical details, lots of examples, really fascinating and interesting, but if you're very sensitive, just be mindful of that, and I think you're going to find it very interesting. Thank you so much, Carron, for joining us for this interesting conversation. We really appreciate your time, and we're looking forward to learning a lot from you today, chatting about your experience during COVID. And we welcome Dr. Hilton Rudnick. Carron, why don't you just start off by telling us a little bit about your background and what's been keeping you busy?
Today I'm speaking in my capacity as a pulmonologist in the Netcare Linksfield Hospital, where we didn't really have a choice. We had to get involved in the COVID pandemic, and I was one of the physicians, one of the frontline healthcare workers, but working in a team with multiple different specialities, allied medical professionals and the nursing staff, and that has been all-consuming. It feels like forever, that there was no room for anything else. So that's been the major challenge, just trying to survive COVID in our own way.
Maybe, Carron, to try and understand like how a day looks for you. I mean, maybe just give us a sense of what happens in the heart of a COVID ward during a surge.
So, I mean, when COVID first started in March last year, I remember one Saturday morning at Shul, a cardiologist who comes to the same synagogue as I do volunteered my services to discuss the new SARS-CoV-2. And I'd been to a lecture that week, so the knowledge was fresh in my mind. And at that stage, we all assumed that it was a normal coronavirus, which we've got 4 of circulating at any one time, that causes coughs, colds, a little bit of bronchitis. Sometimes they get a little bit sicker, but it was a bug that we kind of ignored. And we all assumed it would be a flu-like illness where it was spread by droplets, that you'd get this respiratory illness, and then you occasionally would get complications. And the data coming out from China, I think was the first variant, which was very mild. And then Italy started looking crazy with tents in the parking lot, and we didn't really know what we were going to deal with. And we were having meetings to kind of plan for this. And at that stage, I was going through the protocols, and I was drawing up what would happen if the ICUs were too full. Who would you decide would go in? Who would you be able to take off a ventilator if you had a younger person coming in? And we were anticipating doing that on a daily basis. We thought we'd have lazy boy chairs sitting in our current coffee shop with oxygen machines. We thought there'd be tents in the parking lot. I mean, it was the most unbelievably stressful, anxiety-filled anticipation. And then the first wave hit, and it was a lot of really old people, because it hit the old aged homes. They weren't really prepared. The death rate was quite high, but as much as it was overwhelming, you kind of could deal with it because they were older people with a lot of comorbidities, and you could rationalize that it was okay. And I remember that there was a time where the number of deaths was absolutely overwhelming, because we never had to deal with that volume before, that percentage of the patients who would die. I remember sitting down with my list of patients that I had in the COVID ward and ticking off who'd survived and who'd died, just to make myself feel better, like somebody was getting home. Then the second wave hit, and it was worse than the first wave. And we all thought it can't be much worse than this. And then the Delta variant hit now. And Netcare decided that they weren't going to turn anyone away. So we just kept opening up more and more beds and more wards. And there were times where patients were being managed in some of the theatres. Patients were sitting in casualty. Patients were sitting in ambulances in the parking lot outside. There was one Sunday we were actually examining patients in the parking lot because there was no room in casualty. So a typical day at its worst would start any time from 5 o'clock onwards. You'd get to work. You wouldn't drink anything or eat anything because you knew that you couldn't actually stop for anything during that round. And I was working in a team, so it was myself and my partner, who's also a pulmonologist. We had a dedicated cardiologist, a dedicated neurologist. We had a surgeon attached to us, and this time around, thank God for an anaesthetist who'd moved up from Cape Town because he was very involved in resuscitation. So, the team at various times would get together during the day, but you would start every morning in the donning area, and you would get dressed in layers of, ultimately plastic, and then the N95 mask, and on top of that a visor, and 1 or 2 pairs of gloves, 1 or 2 aprons that you could keep taking off and changing between patients. And then you'd walk into the wards. And this time round, we were using the big ICU, we were using the high care as a COVID ICU, and at some stage we had 8 wards with COVID patients in. So you would start at whatever time in the morning, and you would just go around. One of us would be examining, one of us would be checking the charts, checking the medication, checking the results, discussing every single patient, making decisions together. But it was never a calm, controlled experience because COVID is unbelievably unpredictable. And at any time they'd be calling you for a resuscitation. And often these were patients who had looked absolutely fine 2 hours before, and the next thing you knew, they were in trouble, and we'd be intubating them or calling the anaesthetist to intubate them. Or in the worst cases, which was common with COVID, the hearts would just stop completely and you couldn't resuscitate them. So you were never calm, you never felt controlled. There was always this frantic feeling. I often felt like you were just trying to keep your head above water. It was this surreal environment where you'd walk into ICU, all the staff were in PPE. We looked like Pac-Men because our gowns were yellow. And then you'd look around and you'd see patients, and this time around every single one of them was on one form of ventilatory support or another. So you would have patients on full mechanical ventilation where they'd be out cold in the bed with tubes down the throat, or you'd have patients with masks strapped to their face. And I just remember these eyes, the absolutely fearful, anxious eyes, because they knew they could die very easily. I mean, a lot of the ICU patients die. That's the nature of this disease. And they'd also know that we were doing our best, but we couldn't guarantee anything. And they were very, very concerned about their young families. So the round could take anything from 6 to 14 hours, depending how many patients we were seeing. And then you'd go and you'd sit down and you'd have your first cup of coffee, something to eat, and then you'd start the phone calls. And we were phoning the ICU patients' relatives to update them on a daily basis. And sometimes in the wards where there were demented people who couldn't speak for themselves, or the families needed extra reassurance, so that in and of itself was also quite exhausting. And the nights also were always interrupted. You never had a full night's sleep because you were being called by various wards for advice, or you were running in for resuscitators or whatever. And the volume was so high that we all worked. We all took off like one weekend a month, just after a particularly bad weekend. 2 of us would take off the Saturday, Sunday, and then back on the Monday. So it was very much, my colleague kept saying that it was a war. You'd go in the morning, you'd get dressed for battle, and we were fighting a war that we didn't necessarily understand the rules of because they keep changing. Does that make sense?
Yeah, no, it makes a lot of sense. I mean, did you ever, it sounds like you were never really like fully on top of it. Did you ever start getting more familiar with the nuances of the way COVID functioned, or was it totally unpredictable? Was there anything that made you feel like some familiarity with the way it...
Yeah, very, because in the beginning it was new. And it was like an absolute complete surprise what this bug could do. Because, I've been doing this for 30 years probably. And I've never ever seen an infection like this. And I looked after the lady who had Ebola some 24 years ago. And I remember then we shut the ICU and I put on a full spacesuit with an oxygen machine on my back to go in and see her. And, that was stressful, but you understood it. You understood the rules. You understood what you did. You understood how you got it. This time round, it kept surprising us. But in many ways, we formed a fairly cohesive, intensive care group of specialists in Gauteng. A WhatsApp group was started, and Professor Guy Richards became our leader, our coordinator. He spent all the time reviewing the literature, seeing what worked, what didn't work, drawing up guidelines as to how to treat them. I took that and put it into a format that we all used at the Linksfield Hospital. So I drew up the treatment protocols at all stages, the mild, the moderate, the severe. I did 2 webinars for the GPs on how to treat them as outpatients, a guide, because you've got to use a lot of intuition as well. And then in the hospital, we started doing them. So by rote, you learn the drugs that can be used, and you become very comfortable with it. You can diagnose it easily, you can see exactly what it is, but the actual clinical course is never, ever, ever predictable. And the post-COVID is never predictable either. So although we're very comfortable with it as a disease, it still surprises us. And, if you look at the first wave, like literally 44% of the old people died. And it was a very old population with a few young people. Second wave, I remember doing an article for the Jewish Report. The average age in ICU was 64, and about 24-25% of that patient population died. This third wave, average age in ICU had gone down to between 52 and 55, and our death rate was closer to 30%. And that's across the board. It's not unique to us. It's South African figures. And I heard last week that in province in the Cape, if you were over 45, you were lucky if you managed to get an ICU bed. That's, it hit the younger people much more. So we see a different pattern with each variant. And that's what catches you by surprise, that the variants behave differently. And you can never, ever be complacent. It's an ever-changing paradigm.
So, Carron, recently we had an experience with a friend who had COVID, was fully vaccinated, and then got COVID again really badly. Ended up in ICU, not intubated, but really sat low. And I suppose part of why we wanted to chat to you was, how do we educate or encourage people to get vaccinated? Because in the workplace now, coming back and encouraging people to be vaccinated, you can't force people to, but they might just say, well, you're going to get COVID anyway. What do you say to people who are reluctant to be vaccinated?
I was approached by a pharmaceutical company because of that, where a very big percentage of their staff had chosen not to be vaccinated, and they were in touch with healthcare places. So what I actually did was I took them COVID, so the basic science of COVID, how you get the infection, exactly what it does to your body, and then I showed them actual cases, and the cases were our normal. They were 25-year-olds and 32-year-olds and 38-year-olds and 47-year-olds going up to 90-year-olds. And I showed them like severe lung disease, and I showed them heart disease, and I showed them the 25-year-old who died, where his only comorbidity was that he was a little bit overweight. And I showed them the 32-year-old, perfectly well, healthy, fit man who got such severe heart disease that for 6 weeks he couldn't do anything but lie in bed and breathe. And then I explained that there's no real treatment. Okay, we haven't learned how to stop you getting COVID if you're exposed to it. We can't abort the disease if it's taking hold. And there's no actual cure. There's not a single drug that I can give you that I know 100% is going to cure the COVID. So we're spending our time just trying to mitigate it, to make it less harmful, prevent the cytokine storm, keep you alive. But then there's no guarantees that you're actually going to be okay. There's serious post-COVID repercussions. And then you go into the vaccine. It's established science. By now, there must be 20 billion people who've been vaccinated. You know exactly what the side effect profile is. And if you compare like the worst reported side effects compared to what COVID does, there's an enormous difference. You know, and then there's a lot of data coming from America showing how effective it is. And, you know, if they're open-minded, they'll listen to you saying that 99.5% of the deaths in America were unvaccinated. And that was the you know, now Dr. Fauci said. And then you look at the beta variant in the UK, where they had 52,000 deaths, of which only 1.2% had 2 vaccines. So there's overwhelming evidence that the vaccine's protective, and the chances of getting really sick from COVID is much higher than not. But for me, what's even more important is the fact that being unvaccinated is driving the mutations, and you could theoretically get a virus that is even worse than Delta, more contagious. But also, you can't say you're not going to get COVID if you're vaccinated. Nothing's 100%. But there's no doubt that you get it milder, you're more likely to live. But I can't say nobody dies after both vaccines, because we've seen that as well. You know, so you kind of try and talk them around. You explain to them the vaccine's not going to make you infertile. The vaccine's not going to tag you for people to monitor you for the next 10 years. And I'm very, very pro patients making their own choices. And there were often patients who didn't want to be ventilated, and I respected their decision, and we basically watched them pass away on non-invasive ventilation. I give my patients a lot of autonomy, but the people who are choosing not to be vaccinated are endangering the people around them, and they're driving the mutations. So for me, you then have to say, okay, you can come back to the workforce, that's fine, but you pose a risk to other people. Therefore, you either have to be completely isolated, where you're not interacting with anybody, or you've got to have regular PCRs at your own expense, proving that you're not carrying COVID. You know, I don't think it's something that we need to be like really sweet and kind and gentle about. There are too many repercussions.
Did your talk have an effect? Did it increase?
It was not so long ago, so I thought maybe this week I would actually ask her if people, I must say that I reckon about 20% of the patients that I've seen in the last 2 weeks have not been vaccinated, and the bulk have gone out and had the vaccine once, you know, I'd actually had a chat.
Carron, going back to your point about not, you know, we can't be all nice and soft and fluffy about this issue. Asking your staff whether they're vaccinated or not, even there it's problematic, because there are some people who don't want to share that information. How do you handle that?
See, I don't have it, because every single person that I'm working with in our practice has been fully vaccinated. My family is fully vaccinated. My domestic staff is vaccinated. But I would think, like, I am hearing about it from companies, and they're basically saying that if you're working with people, then it's a condition of employment that you've got to be vaccinated. If you're not working with people and you choose not to be vaccinated, then you can't be with people. So, you know, you've got to be kept, I think you've got to be, you know, hectically monitored to make sure you're wearing a mask at all times, that you're sanitizing regularly, that you've got to eat outside away from everybody else. You know, it's just, there was a very good, I think it was in Ottawa, where the students were objecting. They were saying it was an infringement of their right to be forced to vaccinate. And one of the deans sent out a message saying, we're infringing your rights on a daily basis. You can't drive without a driving license. You can't drink alcohol till you're 21 in Canada. You can't cross the road unless the traffic light says you can cross the road. You know, there are a million things that we're insisting on, and therefore the vaccine probably needs to be one of them as well.
Yeah, I saw that the WITS SRC was also protesting, because WITS brought out a condition of coming back to campus was that you had to be vaccinated, and the SRC took that as invasive, or I don't know, whatever, some tension about individual rights and stuff. So yeah, it's complicated the way people see it. I mean, it does, I think it seems obvious to people who believe in science, and you know, it's like a no-brainer. But you know, I mean, I also do have some compassion for people who, for whatever reason, just decide that they don't want to. I mean, it's hard for me to understand it, And I think that there is a job to try and understand, what it is. Are people concerned that there hasn't been enough science? Are they're just trying to be obstinate about it because they don't like being told what to do? Are they fearful? It's a real mystery around, what's the psychology of people deciding not to? Are there any insights in that?
It's not new. I think it goes, if you go back to like the previous pandemics and the epidemics, it's also when vaccines were introduced, people were warned off them. It was all the conspiracy theories. I think that, for me, it's like people just jump onto bandwagons illogically, like this ivermectin story. I mean, I cannot tell you how frustrating that was, that without any science behind it, without any proof behind it, people were injecting themselves, rubbing it into themselves, taking drops, taking tablets. The poor vets ran out of their cow ivermectin because people were using it. And then there were all these people making it and nobody knew what was in it, and they were all using it, and that they were quite happy to do. But show them actual science and they just don't trust it. But I think that this it's not new. The mRNA stuff has been going for since the 1970s. The other one was the Ebola vaccine, and I pretty much think that all these people that are objecting to a COVID vaccine, if they were exposed to Ebola and we said to them, you have the vaccine to survive, they wouldn't say no. They would take it, because it's more scary.
I think the ivermectin was confusing because quite a few medical practitioners got behind, or seemed to get behind it.
Desperation. The same thing happened with the chloroquine last year,
So this decision to vaccinate has become in some places political. It's a very emotional decision, and it's astounding that even some nurses are refusing vaccination. It doesn't really make sense when you working in that environment and you have the understanding to not be vaccinated, because I don't know where it's going to end up with the labor law. I think some big organizations that we know well are being sued. They've made decisions to insist all staff are vaccinated and share their status, and they've already been taken to CCMA. I don't know what's happened with those cases though, but I suppose time will tell. Eventually they're going to have to make a decision in the law to say either you do or you don't. You're allowed to share. At the moment, from a corporate point of view, it's kind of in your hands whether, as a business, you insist on it or not. But it's a difficult one, because if you vaccinated and you go into the workplace and you don't know who isn't vaccinated, obviously we still got to keep our strict protocols, right? But you don't then feel safe when you go into a workplace if you don't know what the protocols are.
I think they're going to have to incentivize it. That I've got a friend who owns a business, and she's given a 5% discount for people that can prove they've been vaccinated. You cannot believe, like, some people who haven't been vaccinated get so aggressive at 5% that she's once had to march a man out of her shop because he was so upset about it. So I think if you incentivize, it makes a difference. And I think it becomes that the medical aids, if you haven't been vaccinated, you've got to pay more, because COVID's a very expensive disease to treat. And I think that maybe bonuses have to come into it as well, or special discounts on food or something. You've got to make them think a little bit differently.
Carron, what are your protocols once you've vaccinated around mask wearing and social distancing? At what point will we just not wear masks?
I think that when it becomes an endemic virus like the flu, then we'll reach a point where we'll go back to what we were before. I'm not sure in my own mind if I'll ever be as blasé about examining a patient with bronchitis or who's coughing and spluttering without a mask anymore. I can't quite believe we used to do that because it was impolite to wear masks, kind of thing. But I think at the point now where we're definitely expecting a fourth wave, where we're not in control of the coronavirus, where not enough of the world is vaccinated, you have to be sensible. So I'm all for entertaining, but small groups, properly spaced out, wearing a mask, sanitizing, and being respectful, because I know of people who have had close contact with people who were positive and didn't feel like telling anyone or isolating and just carried on going about their business in the normal way. And to me, that's wrong. That's playing with other people's lives. So I said at the moment I just went to a home this morning. Unfortunately, the dad had died, and there were an enormous amount of people there, and the kids just weren't wearing masks. And that's where, that drives transmission, that drives mutations. So I think for now, masks have to be on until such time as it becomes like an endemic disease. When you're outside, you're sitting far enough away from people, the mask can come off. If you're in your own home and you've got people, I often use a separate table, so we sit at 2 separate tables so that we're properly distanced. One person can serve if you really want, and just keep sanitizing. And I think that, that will, I don't think it's the worst thing in the world to have to do right now.
You speak about the fourth wave, so this is just going to be inevitable, or what is going to be the thing that sparks it, do you think?
I think it's not. I think it is inevitable because it's happening all over the world, and like in the beginning I kept trying to talk myself into believing that Africa will be different, that we're not going to be hit as hard because people get sick early, our immunity is better developed, the climate, you look for any reason to talk yourself into not having bad COVID. And I think it's been a lot worse than any of us realize, because if you look on the internet, you look for the excess natural deaths at the moment. And what they've done is they've said, like, a big percentage of those deaths are COVID related. Maybe direct COVID, but also because of the fact that you couldn't get health care or you were too scared to get health care. But if you take that into account, the last figure I saw was that 374 out of 100,000 people have died because of COVID, probably, which puts us 9th in the world. So in fact, we didn't get off as lightly as I thought we had, because last March we were expecting 1 million deaths in Johannesburg alone. That means they were trying to work out where they were going to put all these deaths, and it's been really, really, really bad. But I also think it could be a lot worse. So I think there's a lot more than we realize. I think it's not being picked up, which is fine because people aren't getting as sick, but it does mean that the virus is still there, it's still being transmitted. And then the vaccine uptake has slowed down too much. So you've got a big percentage of people who are not vaccinated. If you throw in an event like Rage last year, we had 1,000 children, of whom I think 95% got COVID. They contributed a lot to the whole beta wave. So if you take, people are very complacent that the virus could mutate, which can happen. I mean, it hasn't yet. There's nothing, there's one they're monitoring in this country, but it hasn't become an issue yet. And you take into account, people will congregate, it will be the end of school, people are going to go on holiday, young people especially misbehave. I think it is inevitable. Having the vaccine doesn't mean you can't get it, but you get less sick, you're less likely to land up in ICU, less likely to die. But what's also very important is that you clear the virus a lot quicker, so you actually transmit less of it. So you're protecting other people and yourself. Yeah, I think Rage could be a problem again.
Carron, I picked up, you spoke about the cytokine storm. Do you want to elaborate on what's going on with that? How does that function? Is it a part of all COVID?
Very, very simply, because it's very complicated, and I haven't actually looked at every single cytokine involved. And they're beautiful, beautiful pictures in the New York Times from last year explaining how you actually get COVID. But you will breathe in or touch your eyes, but either way, the SARS-CoV-2 gets through the mucosa of your eyes into the back of your nose, back of your mouth. And we learned very early on that it attaches to what's known as the ACE2 receptor. Now, the virus is called a coronavirus because it's got these spikes all the way around it that look like a crown, the corona. And they talk a lot about the spike protein, which is these spikes on the surface. But in fact, it's not rigid, it's not sharp, it's not immovable. It's actually, they're beautiful in their own way. They're like fronds that are waving around in the breeze. And they can actually surround themselves with like sugar molecules which protect them from your antibodies. And when they come near one of your cells with an ACE2 receptor, a little hook comes out of the top of the spike protein. This hook attaches itself to your ACE2 receptor. And then the spike protein divides into two. Subunit 1 makes sure it stays attached to your cell. Subunit 2 allows it to get into your cell. It's just got RNA, and RNA is basically like a recipe. It's a recipe that makes the components of new viruses. The virus isn't actually trying to kill you. All it's doing is that it's using you to propagate itself. It's getting into your cells and it's making more virus. So it gets into the cells, the RNA is exposed. It's a very, very complicated structure. It hijacks your own cell machinery. It then produces all the components that it needs to make new virus, and they then get assembled into viruses, and each cell will release hundreds to thousands of the SARS-CoV-2. And then your body realizes that it shouldn't be there. It's a very complicated cellular mechanism involving lymphocytes. A lymphocyte that recognizes that it shouldn't be stimulates what's known as a B lymphocyte, which then produces antibodies. And what the antibodies do is they attach to that little hook at the tip of the spike protein. So that hook is blocked, so it can't attach to your cells. And the second thing is that there are also natural killer T cells that know these cells don't belong, and they go out and they kill it. So if your immune system, the innate, which is the B cells with the antibodies, and then later the cell mediated, which is the memory B and T cells, if they function properly, you'll get the virus, you'll get sick, and then your immune system deals with it and clears the virus. If that doesn't happen, your actual immune system causes massive inflammation, and the substances that you're using to clear the virus start working against you. And you then get what's known as a cytokine storm, because the cytokines, which are supposed to be helping you to clear the virus, are now actually attacking you. And the scary thing for me about the whole COVID thing has been that this virus gets out these cells in your upper airways. It gets into the bloodstream and it affects, like you name an organ, you're going to find coronavirus there. So every single part of your body gets involved in various ways. Even the COVID toes is apparently, like, the little blood vessels have been blocked because of the inflammation on the inside of the blood vessels. They're now saying that if you look at the skin, you can see what part of the infection you're in because of the skin changes, whether it's the acute or the more chronic. So basically the cytokine storm means your body's attacking itself in the worst possible.
And at that point, is there any comeback from that, or does that normally predict that you're not going to make it?
I reckon, you get COVID and all the initial symptoms start because it's in the upper airways. It's the cold, the sneezing, the lack of smell, the lack of taste. Then it moves into your lungs, and that's where you're getting the cough, the shortness of breath, that kind of thing. And then the general immune reaction, which is the fever, the muscle pain, the fatigue. It's always day 8 to day 11 is the danger time, because that's the time that the lungs start getting involved, and that's the time that you need to be in hospital. And what we do then is we give you corticosteroids. I mean, that's the mainstay of therapy, because you're just trying to calm down your immune system. You're basically switching it off. We're monitoring intensively on a daily basis, clinically and on bloods. And if it looks like the inflammatory response is getting out of control, we're using a drug known as tocilizumab, which basically just switched off the immune system. And I reckon like a percentage of people do respond, but I think the vast majority you just can't turn around. So, you're trying, you're using steroids, you're using tocilizumab, you're using oxygen all the time. And inevitably, the heart gets involved, the blood vessels get involved. And then because you're switching off the immune system, the chances of a secondary infection become quite high. It becomes very, very complicated. And the truth is that if you have severe lung disease and then you land up needing dialysis, it's almost invariably fatal. You just can't turn around from that point of view. So the idea is to try very hard not to get COVID, because we know the risk factors. We know if you're old, and old is old. I mean, horrifyingly enough, it's like over 55. It's not 95. But if you're older, if you're obese, you've got diabetes, you've got hypertension, those are all, I think, states that your body's inflamed and has got less effective immunity. You're more likely to get it badly. But we've had people without any comorbidities get very, very ill, and some have died, And also pregnant women. The first wave, no kids, no pregnant women died. The Delta variant, there were a significant number of pregnant women who died. And also there were wards full of children who had COVID, which hadn't really been seen before.
So Carron, what have you and your colleagues done to just manage the trauma that you've been through? I mean, what is the nursing staff and yourself needed to do to look after your own mental health?
You didn't think about it, Colleen. It's like my daughter said it the other day to somebody that, like, I wouldn't have chosen it, and you got backed into a corner and you had no choice, you did it. I mean, there were doctors that chose to actually distance themselves from COVID and stopped seeing patients and stopped, working in the wards. But the bulk of us got together, we worked as a unit, we like supported each other, and you just worked. You didn't think, you didn't react. Sometimes it was overwhelming. I mean, I remember one night, particularly, I'd been called in for a resus on a woman who, I think she just got really tired and she stopped breathing. And thank goodness, our anaesthetist was there and he helped me with her. And then as we were settling her onto a machine, we heard screaming coming from around the corner, and we all went running. And there was this 32-year-old who had a child 2 weeks before, landed up in the COVID ICU, and was doing relatively well. I was actually looking at going home within the next week. It was a Sunday night. She'd had a long video conversation with her parents, her husband, her 4-year-old. And that night, like 11:15, her heart just stopped. I remember we all ran there, and I think everybody just kept going for like an hour and a half. And probably within 20-30 minutes, you're not going to win. But because she's young, she's got a baby, you just can't stop, and eventually you make the decision to call it, to say, we've lost, And that was the night that every single person burst into tears, and then you just pick up the pieces and you keep going. And I think in many ways, it's what you're trained to do, but this was much worse than anything we'd seen before. And you just keep going and you keep going, and it does affect you, because at night I found that I'd go through the worst cases, all the families that I was speaking to, the goodbye calls. Those are also very, very hard to deal with when you had a 34-year-old and they were exhausted, and you say, do you want to be intubated? And they say yes, and then you know how tired they are. And you say, do you want to call your wife? And it's the goodbye phone call, and you're holding the phone to their ears. Or once I was the intermediary, saying what he said and what she said, and it was that kind of thing. And I think we're still dealing with it. We function independently. We're not really employed by the hospital. We have admission privileges there, so we would have to kind of do things ourselves. The nurses were offered trauma debriefing. They've got trauma counsellors. I think they employed extra social workers. But I think a lot of the time it was just everybody was in the same boat. Everybody could cry together. Everybody could just support each other. And every now and then there were amazing people in the community that would send muffins and cupcakes. And the one man in high care bought everybody Kentucky Fried Chicken. And the one woman in the one ward was very, very cold one night, and they wouldn't give her a hot water bottle because it's against policy in case she burns or whatever. So when she got discharged, she gave each nurse a water bottle with a personalised note, and that kind of, it did help. The other thing for me, and this is a very personal thing, was that a lot of the time when somebody's dying, you actually can see the spiritual element and you can support them. So it was very hard to find a spiritual element. And then I had a young pastor. He was 34 and he got really, really sick. And he knew where he'd got it because he'd gone to work and he was with the staff that he was comfortable with, and he took off his mask and they all sat around, So he knew, so there was a lot of guilt there because he took it home and he gave it to his entire family and his mother-in-law and his domestic. And, he was in the downstairs ICU and he was desperately ill and survived. And I saw him about a month later and I said to him, I'm struggling to see the spiritual element in this. What's your take on it? And he said to me, God doesn't cause illness. He's got absolutely nothing to do with it. But when you're sick and you need him, he's there. And he said that being in high care and being absolutely terrified every single minute, he felt God's presence like you can't believe, and it reaffirmed his faith in God. So, there was that kind of element as well. And, so the bottom line is that I think a lot of talking about it and going through stuff like this now, I think that's my way of doing it. I think some people have gone for proper post-traumatic stress counselling, which is necessary. I mean, anxiety is a huge big thing for the staff and the patients, I must say.
Carron, I was just thinking, when you think now about potentially another wave, does that fill you with fear or?
I have to be honest that working as a team for me meant that there was no second guessing myself. So if the 32-year-old died, I wasn't thinking, what did I miss? What could I have done differently? How could I have changed things around? So the fact that you work as a team automatically makes it easier to deal with. It's also very familiar. In the beginning, I drew up the donning and doffing protocols, and we used to stand and read step by step how to get dressed, how to get undressed, because the undressing is when a lot of people get COVID. Now it's second nature, plus they've employed these sweet little girls. They're young and they're there to dress us. And they've been told that if we come in and chat, they can take their time. If we come in and we don't want to talk, they know it's an emergency. They must dress us very quickly. So all of that's established. But I also think that, this next wave is going to be a lot of unvaccinated people, where I've had people that, where people have deliberately flouted the lockdown restrictions. So when they shouldn't have, they've gone out to a restaurant in a big group, they've sat on top of each other, they've gone home and they've given it to their older relatives, and then we've had to deal with the older relatives dying in ICU and the fallout from the family. And you kind of think that could have been prevented, but it doesn't stop you treating the patient you should. But you have to wonder, if you're fully vaccinated and you come into contact with some idiot who chose not to be vaccinated and he gives you COVID, and you're older, or it's 9 months since the vaccine and you haven't been offered a booster, or you've got one of the autoimmune diseases, or you're on chemo and the vaccine's not as potent as it should be, and you get COVID, and there's a man who chose not to be vaccinated and he got COVID, and I've got one ICU bed, who am I going to give it to? Because we were picking and choosing this time. It wasn't that you could just put in everybody you wanted into ICU. So that I think might come into it. And there are who gets into ICU and who doesn't. There's established protocols, and this might well become part of it. If you're 30 years old and you've got, I don't know, some disease that's you're only going to live for the next 6 months, you're not going to get an ICU bed if there's a resource. Unfortunately there is a degree of picking and choosing, but we discuss it. It's never, there's 6 of us and we discuss it. So it's not that the burden falls on one of us. We've got an outstanding psychologist that can help us, and we've got a very experienced ICU nurse counsellor that can get involved in the decision as well. So it doesn't compromise the patient's care. But I just wonder because my anxiety levels go through the roof when COVID's at its worst, and you just, one weekend on the Saturday, 6 resusces, on the Sunday, 6 resusces, 8 on Monday, like another 4 and 8 deaths, and you just wonder, like, you know, that degree of anxiety, whether it would be a little bit less if you know that they've been idiotic and they've chosen not to be vaccinated, and therefore they know that they, you know, potentially doing it to themselves. So we'll see. And I probably shouldn't be talking like this, but it's the reality.
No, it's interesting. I mean, you're a human, you can't help that. So, and that's your response to it. I'm very interested in the leadership component of working in a COVID, and not only COVID, just in a medical unit like you are. You talk a lot about the team and how the team makes decisions together. And I'm just wondering, like, about the leadership lessons that we could take from you into into the corporate world, which is where we mostly work. I mean, it sounds like there's just a lot of consensus building, that there's like no one really taking charge, but as a unit, you just put all the best of your thinking together and make decisions. Or am I getting it wrong?
You know what? Doctors are very complicated human beings, I think, and they probably choose to do medicine for unusual reasons. And I'm not the normal. I definitely don't. I don't believe that we don't make the ultimate decision. So you take the best advice that you can and you implement it. And it doesn't work across the board, but I work with another pulmonologist, so there are 2 of us. And then we every day would give a list of cardiac assessments to one of 2 cardiologists who were attached to us. There was a surgeon that would come in and help us with lines. We had the anaesthetist come in and help us with intubations, lines, arterial lines, that kind of thing. The psychologist came in sometimes and helped the patient. So, you know, my focus is very much in taking care of all the patient's needs, not just the ventilation and the oxygen and, you know, the stuff like that. The others that work more independently, that are less likely to take advice, that are more prickly, more, you know, they're definitely various personalities, and everybody handles it a bit differently. But we're a small clinic with a small group of doctors that, you know, that was one of the things that I liked from the beginning. It felt like it was like a family that supported each other. And what we did is that twice a week we'd have a meeting and we'd explain to the rest of the hospital how many cases we had, how many were in ICU, and then how many admissions, how many deaths, that kind of thing came into it. So I think you've got to have a captain of the ship. And in many ways, you know, Guy Richards took the helm of the clinical decision making. And then within the hospital, we'd meet, and it was the physicians, probably 3 of us out of the 6 that, and oddly enough, we're the 3 older ones that would, you know, make decisions together. And often we were on the same page, you know, which is why it's been easy to work in the practice. So I don't know. It's my sister works in the corporate world. It's a completely different environment.
I mean, what I take from it in a way is that you all have your own specialist knowledge in a way, and you pull it together. So you rely on someone who, you know, you're aligned, but they've got their like niche, they're an expert in that, and you trust them to do that part of it. And I do think that there is an analogy of that in the corporate world, is that you have to trust the people around you to give their very best to make the whole machine work. And, you know, you have to let go of, you know, that they're doing their part. And I know that you said you work more holistically, that you're involved in a different kind of way, that you're not just there as a physician, you're there actually, it sounds like more holistically. Did I get that right?
I think, like, and I don't know, like I've been in this clinic since, well, it's 20 years now. And in all that time, I've never seen any of the ICU sisters call any of the men to come and comfort family members or get involved in a family fight. But the women get called quite quickly. So I think the 2 of us, they're 2 women, we have a very different take on it, and we're much more emotionally connected, and we're much more worried about, like I'll walk in and say the family's coming, brush the hair, shave the face, make sure everything's neat and tidy. You know, to me, that's important, that you walk in, and even if the person's completely unconscious on the bed and under an anesthetic, they've got to look nice, and the environment's got to be tidy. And, I have a completely different take on things. So, I see it differently. I see the spiritual aspect very differently. But also, ultimately, in the case, as they keep saying, the physician's the captain of the ship. So we make the ultimate decision. So you're very much calling in people that you trust. And we do hand over because we trust the other specialities implicitly, 100%. They're excellent in what they do. We rely on them. They make decisions. We either implement them or we don't. But ultimately, it rests on our shoulders, and we're the ones that are phoning the families and, kind of making, the bigger decisions than the others. So I think the team is very important. And I think, sometimes the egos are too big and need to be stoked too much, which I find quite annoying. But, I think, you've got to trust the people around.
It's interesting, Carron, because when I listen to you speak about how you work, typically in a private setup, physicians and specialists would do their own thing, and there was always this sense of very fragmented medical care. Like when we worked in the hospital, the gen, we do the ward rounds, and all the different specialities are there at once. And it just sounds like that it's shifted a little bit, and that the patient care and the medicine that's been given is much more, integrated than it was before.
Colleen, it has to be, because the subspecialties are now so complicated and so vast that you actually need you need the cardiologist to come with his echo machine or whatever. And we've had everything. We've had the vascular surgeon have to amputate an entire leg. We've had the neurologist being called in for everything from Guillain-Barré to strokes to movement disorders. The psychiatrist a lot. The renal unit are dialyzing. So we rely on them very much. But where private differs is that you are it. I remember when I was in state, you were up here, and then you had your fellows and your registrars and the MOs and the interns, and you came in and you gave advice and you supervised, had lots of time to read, but you weren't at the coalface. You weren't the one actually dealing with the patient and the relative. So that's what's different. I had a patient whose son is a pulmonologist in Jerusalem, a son-in-law, and the man, old man, he was dying basically. I can't remember the cause, but the daughter and son-in-law were sitting next to the bed, and he said to me, what shocked him the most was that there were no MOs and interns to run around doing anything. You were it. So in many ways, private's got an advantage from that point of view, because everybody's qualified, everybody's specialized, and you've got a lot of subspecialities. And Linksfield is small, and we are a very cohesive group on the whole, the entire doctor body. So from that point of view, it was good.
Sure. Well, it's been so amazing listening to it from your perspective, because I don't think one can often hear the coalface story. And I just want to thank you so much for, just being so open and sharing, and really appreciate your time. And I hope people listening will understand the impact, and, I'm sure just take some precautions when they listen to you, because it's almost like COVID is just something you hear about and you don't experience it like you do. And in that way, we're quite detached from it. So although it's quite graphic, it's necessary that we hear the details, I think.
Nice if we could bring people in to actually see, because that's the way. That's when the relatives came in and saw. This time around we let them come in when the patients were really sick, and that was the wake-up call. That's when they went out and started spreading the message of how bad it really is, because the majority are actually okay. You don't see the worst part necessarily. So it's very, very, very difficult to put into words. It's something that you feel and you deal with, and I never felt like we were triumphant. I never felt like we had conquered this disease. I felt like we were very comfortable with it, and I don't think that we've seen the end of it yet, but please God, it will just become an endemic bug and we'll back to normality. But hopefully with our priorities a little bit.
Exactly. Hilton, anything from your side before we end?
I did have one last question, but I know you've kind of wrapped up a little bit. But I just wanted to ask Carron, you spoke quite a few times about the kind of spiritual component, and I mean, you have to be a scientist to be a physician, and you have to really trust science in doing what you do. Did you come across things that were just like, I guess like a miracle would probably be the best definition, but like things that were just unexplainable to you, that went in the way that you couldn't understand, that just seemed miraculous? Or was there always like a science explanation for you?
No, because to me, what I realized very early on is that I feel like we've been given the tools and the knowledge, and we try our very best, but we don't make the ultimate decision. And you can take two people exactly the same way. One you think's gonna live and they die. One you think's they're gonna live. And like early on, like patients, I had a young patient who had got involved with a very alternate healer who stopped all her medication and told her parents and I were trying to kill her. And I remember she was 20 and I was new at this game, and I wasn't like now it would be easier. And I remember going to her bed one day and touching her hand, and she opened her eyes and she said to me, when you touch me, I can't tell the difference between you and my angels. You feel exactly the same to me. And she took another 2 weeks to die, but there was a very, very spiritual component, because she could talk about her angels and her guides and, the spiritual beings that were around her bed. And I absolutely believe it. And with normal deaths, patients talk, you can see it, you can feel it. Then I had a patient who, on the table, she was about 50, she was having a relatively straightforward op, and on table, she died. Her heart stopped, they started resuscitating her. She told me, she lifted out of her body, she looked down, she could see what was going on. She went across to the most beautiful garden. Her father was waiting there, and he said to her, "You've still got stuff to do, you need to go back." She went back. And she said to me she'll never be scared of dying again. So it was one story like this after the next, except for COVID, because it was so terrifying for everyone, including the patients, that it was happening too quickly, too aggressively, too much. There were very few of these stories, except one man, also a young man, who was absolutely terrified. And I'll never forget the day I went to his bed and his oxygenation was 96%. And I said to him, "You through? You fine?" And he typed a message to his wife to say, the doctor says I'm fine, I'm going to be coming home. And then the physio put him into the chair to sit. And he then he said to her, "Actually, I've decided I want to go." And then he died. You know what I mean? But his phone was open on this message. Then you have my pastor telling me that God was with him in the ICU, which was very nice to hear. Then you have another man coming in saying to me, and I knew him vaguely from the community, saying that he knows I will look after him in every single way. And when he dies, I'll be there to help him over. And then you have the man who, his entire family was in the Linksfield clinic, including his mother, and the mother died. And I remember saying, "God, if you had to take one of them, thank goodness it was the old lady, and you're going to spare the parents and the child." And he was looking like he was going to go home, and they called us for a resus, and we went there, and he said, "I went somewhere unbelievable, and then I came back." So there's always this element. So, I kind of believe we're not ultimately in charge. I really do believe that whatever spiritual being you believe in and your own soul decide whether you're going to live, whether you're going to die, how long it's going to take, because sometimes it takes forever and sometimes it's very quick. So, that was missing, because it was just too much. It was too many and too quick, and, no time to kind of, at some of the time there was. My ones that chose not to be intubated, that was easier to understand what was going on and for them to speak to their relatives. Then you could see the transition. But that was a difficult time, I think, spiritually for a lot of people. But at the same time, you'd walk into high care on a particular bad day, and they'd all be standing and praying and singing beautifully, because that's where the nursing staff found their comfort, you know.
Okay, yeah, thanks, Carron. I mean, in a way, it seems like, your whole life and everything you've done has led to this moment. You were in that place at that time for, that's why you did medicine, for that, right? And I mean, it just, it all came together for you, and it sounds like you were heroic.
Thank you, Carron, again for being so open and sharing your experiences and insights with us today. The care and medical expertise you have provided to all your patients and their families has been simply incredible. If you made it all the way to the end, DM me the word orchids on the Twitter handle linked in the description below, and I will send a mystery gift. Please subscribe to us wherever you get your podcasts. Thanks again.